Good evening, everyone. My name is Carolyn Brown, and I am the Senior Associate Director of Development and Community Engagement at Penn Medicine's Basser Center. On behalf of the Basser Center, I would like to welcome you to tonight's panel discussion, BRCA and Ovarian Cancer Risk Reduction, hosted by the Basser Center's Young Leadership Council. The Young Leadership Council is a dynamic group of 167 men and women across 29 states who are volunteers and supporters of the Basser Center, passionate about changing the options that currently exist for BRCA mutation carriers for generations to come. The experiences and opinions shared tonight are the panelists' own and do not represent those of the Basser Center, its Young Leadership Council, or Penn Medicine. You should consult with your healthcare team should you have any questions about the specifics of your health and medical plan. Thank you to our panelists for joining us this evening for this important discussion about ovarian cancer screenings, risk-reducing surgical options, hormone replacement therapy, and relevant topics. Erika Stallings, who will be moderating our panel this evening, is an attorney based in New York City, where she currently works as Senior Product Counsel at Bandcamp Epic Games. Erika is also a freelance writer and has been published in the New York Times, Washington Post, O Magazine, The Cut, and other venues. Erika is a dedicated member of the YLC, having served as an inaugural co-chair since 2016, and is a founder of the Basser Center's Black and BRCA initiative. And with that, I'd like to turn it over to Erika.
Hi, before we get started, can everyone please mute their lines just so we can make sure that everyone can hear the really exciting discussion that we're having this evening. There will be opportunity for Q&A, which I'll talk about, but I just want to make sure we have some really great panelists who have volunteered their time this evening. So, thank you for good Zoom hygiene. Carolyn, thank you for that introduction. I'd like to get the evening started by introducing our panelists. And as I mentioned, I just want to thank them for generously offering their time, expertise, and personal experience to this important topic and important panel. Dr. Danielle Burkland is an associate professor of clinical obstetrics and gynecology and is the director of the Helen O. Dickens Colonoscopy Clinic at Penn Medicine. Dr. Burkland's clinical practice includes the full scope of office gynecology and obstetrics, with a special interest in gynecologic issues in breast cancer survivors. Dr. Burkland completed medical school at Rutgers, New Jersey Medical School and her residency at the Hospital of the University of Pennsylvania. She is a member of the American College of Obstetricians and Gynecologists, the AMA, the Menopause Society, and the American Society for Coloscopy and Cervical Pathology. Kristina Coccoluto is the daughter of a two-time breast cancer survivor, niece of a woman who died from BRCA-related cancer, and the first person to outpace cancer in her family after testing positive for a BRCA1 mutation. She is a mother of 3 young children and underwent a risk-reducing mastectomy at 30 years old, and the I'm never going to say this correctly, salpin ovarectomy at 36 years old. Kristina is a storyteller, motivational speaker, philanthropist, and 3-time Abbott World Major marathoner. This past September, Kristina ran her 4th Abbott World Major in Berlin, raising money and awareness for BRCA mutations. She is passionate about the mission of the Basser Center and strives to see advancements in research made with hereditary cancer for the next generation. Our third and final panelist is Dani Nodelman, who lives in Livingston, New Jersey, with her husband, Mark, and 3 boys, Drew, Reed, and Chase. Having a strong history of breast, ovarian, and peritoneal cancers, Dani tested positive for a BRCA1 mutation and learned that her aunt and 5 great-aunts had a BRCA mutation as well. Dani was empowered to make the decision to undergo a prophylactic bilateral mastectomy and a complete hysterectomy. Despite the many challenges along the way, there is not a moment of regret in the difficult life-altering decisions that were made. Dani is also a member of the Basser Center's Young Leadership Council and has made it her mission to pay it forward to help young women and men make the right decisions for them regarding their own BRCA journey. So again, thank you all. I just want to mention as a note of housekeeping, we will be leaving some time at the end of the panel for Q&A. So please drop your questions into the Zoom chat and we will hopefully get to as many questions as we can. If we are unable to get to your question, or if you're interested in learning more about the Basser Center or the Basser Center Young Leadership Council, please feel free to reach out to Carolyn Brown, and she will share her email and contact information in the chat. And with that, let's get started. So Dr. Burkland, just to sort of set the stage, could you tell us about the ovarian cancer risk for BRCA mutation carriers? And if that risk level is different between BRCA1 and BRCA2 mutation characters, or whether having a family history of ovarian cancer impacts that risk as well?
Thank you, Erika, and thank you everybody for joining. And I'm very humbled to be sharing the stage with women with such amazing stories that I look forward to hearing about soon. So when I sit down and talk to patients about the BRCA mutations, we generally talk in a range of risks for BRCA1 and BRCA2 in terms of ovarian cancer risk, because it's a little bit harder to individualize very specific risks for patient to patient. And just a little background on how we know this information. We have several large meta-analysis studies as well as prospective studies that give us these numbers. There is a difference between BRCA1 and BRCA2 mutations. And then even within the, if you have a carrier mutation in BRCA1, within that gene, there could be different types of polymorphisms that also alter your individual risk of ovarian cancer, but we don't always know that information when we're counseling patients. So the lifetime risk for BRCA1 patients is the range that's given is around 40 to 60%, with an estimation of 50 or so % by age 70. For BRCA2, the risk is going to be lower, around 11 to 20% in terms of the range, 20% by the age of 70. And then other thing I would just add, because I don't know, how much people know, but the BRCA1 and 2 are tumor suppressor genes, and they encode for proteins that basically function in our DNA repair process. And it's transmitted autosomally dominant, meaning that if you get the mutation, you have the potential for these cancers. But there's 2 copies of it. And so there's usually what we call a 2-hit hypothesis, where you have a mutation in one, and then environmental factors, other genetic factors affect the other mutation, and that's when cancers start to happen.
Got it. And something that I think probably a lot of our listeners are dealing with, and something that I have dealt with as well, is that there are very few tools we have to detect ovarian cancer, particularly at an early stage, as compared to, breast cancer, where you have, mammograms and MRIs, which BRCA mutation carriers are at a high risk for. So would love if you could just sort of explain what the current ovarian screening options are for BRCA1 and 2 mutation carriers.
Yeah, so this is definitely still a continued area of disappointment with results. And someone needs to mute. There we go. And I, in preparing for this talk, I reviewed a long article, and, I don't think we have anything coming down the pike immediately, but there's definitely some good ideas there. When I think about screening for any sort of cancer, the cancers that we've been successful for, cervical cancer, colon cancer, they have very well-defined precancerous states that we have a tool to identify. And then they have a very long, what we call lead time, from the time you have precancer to the time a cancer develops. And those are 2 things that ovarian cancer doesn't have. We're starting to get to a point where there is what we think a pre-invasive lesion that is associated with a lot of the BRCA-related cancers, but being able to find that is still very far away. And then again, knowing how long when you have the pre-invasive lesion to cancer does not seem to be a very long time frame. So currently, in terms of what options we have to detect at an early stage, they've looked at a number of different things in high-risk patient populations, so BRCA carriers and some other gene mutations. They've looked at transvaginal ultrasound alone. They've looked at transvaginal ultrasound done with CA-125s. They've looked at, and let me just say, CA-125 is a blood test, and obviously the ultrasound is an ultrasound. They have something called a risk ovarian cancer algorithm that takes a CA-125 level and several other factors about the patient and gene mutation to try to refine that number and also look at the change over time. That was really the last randomized trial that was done in the UK. They did, out of the cancers they found, 50% were found in an earlier stage, but there was a lot of kind of confounding issues in terms of being able to identify whether or not this actually changed overall survival. And so not just finding the early stage cancer, but making sure that that actually reduces or actually improves survival rate for carrier mutations. So currently the last 2023 national NCCN guidelines, which is what we use, actually doesn't have a recommendation for ovarian cancer screening right now. I will say that practically a lot of us will offer patients the ultrasound and CA-125s until they're ready to have a risk reducing procedure. And if they opt never to have a risk reducing procedure, consider continuing that. Knowing that we don't have evidence to support that it's definitely going to prevent a cancer for them. I guess I'll stop there. I think we have a few more about this.
Yeah. Well, no, I think, with the caveat, that it's not NCCN recommended, for BRCA 1 or 2 mutation carriers who do want to opt in to those screening processes, the transvaginal ultrasound and the CA-125, at what age do you recommend that people start those? And is there a particular type of doctor that individuals in this high-risk category should see or consult with?
Yeah, so the overall rate of ovarian cancer under the age of 40 is lower. You do want to take into account the family history as well. So if there's a family history member with ovarian cancer and they were diagnosed, say, at 40, we generally think about at least 5 to 10 years before that. Or what if you had a sister who was diagnosed at 32 and you're 25? Like, when do you start for that person? And one of the issues with both of those screening interventions is that the CA-125 levels are often elevated for normal reproductive reasons, changes in the time of your menstrual cycle, having a normal, normal follicular cyst, endometriosis has elevated CA-125 levels. So they're not great options. Kind of getting a little bit off the tangent, but to go back to kind of the very specific question, generally we talk about screening somewhere between 30 to 35 and 5 to 10 years younger than the youngest affected family member. And whichever one of that is sort of the youngest of those. But it really does need to be a pretty long discussion about the potential lack of proven benefit or potential lack of benefit, or at least not proven yet, and the false positives and what those false positives mean. And then in terms of what type of doctor you should see, I think that's a really interesting question. So I think there are some medical oncologists who specialize in the field who really manage both the breast and ovarian cancer screening, but some really want the gynecologist to manage the ovarian cancer screening because the interpretation of ultrasounds can be a bit overwhelming if you're not constantly dealing with pelvic ultrasound results all the time. I generally recommend seeking care with a gynecologist that's working in an academic institution. There's sort of a subsection of OBGYN that's called the academic specialists of obstetrics and gynecology. And those are really OBGYNs who have dedicated their life to both teaching, education, advancing the field without necessarily having a specific discipline like a GYN oncologist or a contraceptive expert. And the last thing is there are some GYN oncologists who also do a fair amount of this preventative care for premutation or for mutation carriers.
Got it. Dr. Burkland, thank you for doing such a good job of sort of setting the medical background and staging. And with that, I'd really love to bring Kristina and Dani into this conversation. So for both of you, could you just share with the audience about when you first learned about your BRCA mutation, how doctors sort of discuss this risk of ovarian cancer with you, and what the available options for managing your risk were? Maybe Dani, if you want to go first, and then Kristina jump in.
Yeah, sure. My dad's sister was diagnosed with primary peritoneal cancer when she was, I believe, 48 years old. And prior to that, we had no knowledge of our family history. And with her diagnosis, she implored my sisters and I to get tested. We learned that my dad's 5 aunts all died of breast or ovarian cancer in their late 30s, early 40s. So with that, I got tested, learned of my BRCA1 mutation, and from there set on my journey of surveillance first and then prophylactic surgeries. I first met with, it was just a rush of testing and a rush of meetings with physicians. I met with Dr. Offit. I met with a number of geneticists at Sloan Kettering, and ultimately decided to undergo the prophylactic surgeries after I had all my children. I was only 33 when I found out. And from the time I was 33 to 38, I had 3 kids and then set on my journey.
Wow. That's all. I mean, yeah, I think we'll have some more discussion around that.
Yeah,
Kristina,
sure.
would love
Yeah.
to hear from you.
Thank you. Thank you everyone for having me here tonight. And Dani, thank you for sharing your story so openly. I actually found out I was BRCA positive when I was 25 years old, but at first, when I was 20, I was diagnosed with melanoma. And I know that I'm sure, Dr. Burkland, you can say that there's not really a direct link between BRCA1 and melanoma, but it was just a little bit of a red flag because every woman in my family on my mom's side had already had breast and or ovarian cancer. So I kind of grew up always just assuming that breast cancer was in my future. And so at 25, I was tested and I didn't have genetic counseling. It was one of those things. I was actually in a relationship with who's now my husband, but we are high school sweethearts. And at the time I was really trying to figure out if I was on the right birth control, where I was going with my family planning. And we were both, 25 at the time and not married. So when I decided, I was having this conversation with my doctor, my gynecologist said, you should really think about getting tested for the BRCA mutation. And it wasn't something that was greatly talked about in my family. I don't think my mom or my aunts were really open with their journey as much. We all knew that they had cancer, but it wasn't something that, was openly discussed. And it just was not secretive either, but just not something that you'd want to bring up. And I realized that that's why I'm really open, because I realize that ability to share your story is what makes us all realize that it is so normal, and knowing your family history is so important. So by the time I was 30, I had one child. I was married, fast forward, one child, married, and decided it was time to have a prophylactic mastectomy. And that was because I had found a lump in my breast, and the screening process of every 6 months surveillance, I just realized that I was ready. I was not done having kids, but I was ready to kind of face, so that my daughter did not have to have the same fears that I had with my own mom. And so I ended up, after 1 month after reconstruction was over, I got pregnant with my second child. And by 33, I had my third. And from basically 33 to 36, I felt like I was rolling the dice with my ovarian health. I just was always playing in the back of my mind. I just never felt like, because the screening, as Dr. Burkland explained, is not really great. It was something that just made me feel like, okay, I need to take this next step. So at 36, I had my complete hysterectomy.
Got it. And I wanted to sort of dig in a little bit more, because both of you have undergone these preventative surgeries, just about how you actually came to the decision to do it, and then actually what that process was like for you, including, the recovery time out of, both, I would say, physically and mentally, to the extent you want to share. So maybe Kristina, let's start with you, since Dani went first last time, and then Dani, you can jump in.
Sure. For the complete hysterectomy?
Yeah.
Okay. So I actually I will share that this night, I know my experience is my experience. And I just want to say that to everybody, you might have had different experiences or as you go through, but I will say that I was really mentally prepared for my mastectomy. And the reason why I'm bringing that up first was I wasn't for my complete hysterectomy. I felt like it really snuck up on me. And so I know we had mentioned in my bio initially that I was a marathoner. And so I ran my first marathon before my mastectomy to kind of quickly prove to myself that if I can run a marathon, I can walk confidently into an operating room. And I recognized that all of the momentum for training for a marathon, I really truly built up my confidence for the mastectomy. And then for this hysterectomy that I had, it was one of those things where I felt like when I had told my community, a hysterectomy is almost seems so much more common than a mastectomy to, I'll say, cancer muggles, right? Like, I don't know how else to put it, but when I had stated that I was having a hysterectomy, it was like, nobody really understood that that meant I was going to go through surgical menopause in my 30s, and that that's not something that is common for someone in their 30s. So I felt like the reason why I chose to was actually I was going for a breast MRI and I had a severe panic attack. I had never had one before in my life. I had no idea. My sister was with me. And as I was getting ready to go into the MRI, I realized that all of the mini traumas that we built up through surveillance were starting to catch up with me. And I'm somebody who can kind of do anything mentally in my mind. So like I gave birth without drugs, like I was like, okay, I can do this. It's just an MRI. I've been doing them every 6 months since I was 25 or a year, every year. So I've been doing surveillance forever. And as I was laying down face down in the tube, it just hit me like a ton of bricks. Like, oh my God, I don't want to do this anymore. I don't want any surveillance anymore. I want to minimize my surveillance as much as possible because all along I was feeling things. I could do anything, but I was kind of quieting my mind and the anxiety and what I thought was making myself feel less anxious. Really, I was just stuffing my emotions down. And I don't know, I'm sure maybe Danielle, you can relate to that as when it comes to the surveillance, but the surveillance piece for me was a lot. So I realized I did not want to deal with that anymore. And that was what made me say, I'm ready. And I know that there'll always be some level of surveillance, but not to the degree of where I had the same risk.
Yeah.
Yeah, we actually have similar stories in that respect, other than the fact that I was always more fearful of ovarian cancer than I was of breast cancer. So it was a little opposite there. From the moment that I heard that I was BRCA positive, I always knew that I would undergo the prophylactic mastectomy and hysterectomy, not even a salpingectomy. It was going to be the full, complete hysterectomy. I wanted nothing to do with my body parts when I was done having kids. So at 32, I was married, newly married, did not have any children, but started a surveillance program and continued that surveillance program for years as I was having my children. And I just recall every time I would go to Sloan Kettering, I would have the same routine. I would go to Starbucks to treat myself. I would get my breast MRI and my mammogram. I would call one of my sisters along the way, crying, I know I have cancer this time. I know it. And then afterwards, I treat myself to a Lululemon something or other right around the corner. And the mental toll and emotional toll that it took on me was really it was really something else. I mean, I knew that, like you, Kristina, I wanted to be done with surveillance. Every 6 months of some surveillance mechanism was enough. So I had so that was after my last child was born, April of 2015, exactly 6 months to the day, I had first the complete hysterectomy because, like I said, I was more fearful of ovarian cancer because I knew that it was more difficult to detect ovarian cancer. So I had a complete hysterectomy, went into surgical menopause at 38, and exactly 6 months to the day from there, one day after my son turned 1, I had the prophylactic bilateral mastectomy. And I think, Erika, you asked about recovery. For me, the hysterectomy recovery was very easy. I left the hospital with hormone replacement therapy. I had a patch. I didn't even know I was going to leave the hospital with a patch on, but I looked down and there it was. And I really had very few complications. I feel very fortunate in that maybe a hot flash here and there, maybe we adjusted the patch dose, but the worst part about the hysterectomy was the gas that kind of crept up in your neck and shoulders. And, if gas is the worst part of the hysterectomy, then so be it. For me, though, the recovery after the mastectomy was the most difficult. I had complications. I'm not going to sugarcoat it. I had necrosis. I had capsular contracture. That's where my body pretty much rejected the implant. And after the exchange, I had about 3 subsequent surgeries to fix that. Actually, I think it was 4, all within a 2-year period. So, it definitely, it took its toll. But, going into surgical menopause at a young age, at the time, the symptoms were, okay. I was okay. I'm 10 years older now, and there are certain things that have crept up, osteopenia and certain things that, crept up from these prophylactic surgeries, but, wouldn't change my decision at all.
Erika,
Yeah.
I just want to add too about my recovery, because I hope that this gives anybody who's listening some hope on that, is that my recovery, I gambled on my recovery. I took a huge risk. My sister, I don't know, Dani, if you have siblings that have also tested, but I have 2 sisters, and one tested negative and one tested positive. And so my sister was on this journey with me from the very beginning, from the moment I got tested, and the sister that was positive. When I said I was going to run a marathon to lead me into my mastectomy to gain strength, she was like, well, you're not running it alone. I'm going to run it with you. Mm-hmm. So when she decided this past year that she was going to have her mastectomy, she was like, hey, just want to let you know, I'm running the Boston Marathon. And I looked at her and I was like, that's on my bucket list, but I'm having a hysterectomy. And then I looked at my calendar, and it takes 20 weeks to train for a marathon. And it was 8 weeks for recovery for me. And I'm sharing this because from the Monday of my hysterectomy till Marathon Monday in Boston, it was exactly 28 weeks. And I was able to recover and run the Boston Marathon this past year. So wow. In a 28-week period. So if you're watching this, wondering like, can you resume a life again? Yes, you can. You absolutely can. You can recover quickly. And like Dani said, I thought the worst part was feeling the laparoscopic air in my shoulders. So I just want everybody to know that the recovery is not nearly as bad as you may think. And the worst part of this entire surgical process for me was the weeks leading into surgery, because I had the worst anxiety I had ever had in my life. I felt like, and I want to just validate everyone's emotions, because I felt like I was on a cliff, like on a train heading towards a cliff, and it was going as fast as possible. And I felt like I was giving up and forfeiting my youth. I had already forfeited my breasts. And I, for the first time in my life, had a really awful pity party. And that was not like me, but I was terrified of the complete hysterectomy and walking toward menopause. And I too I am on HRT, and my symptoms have been minimal. I felt like one of the best things that it was when a doctor really taught me how to use it properly and really focus on the time release aspect of when I'm putting my patch off and when I'm taking it on and putting it on. That was something that was a game changer for HRT. But I just wanted to say that you absolutely can recover quickly and resume your normal life. And I know a lot of people ask about, like, when did you go back to work? So I think I had 8 weeks of no driving. That was a lot because we have 3 kids. So, other than that, it was really, really wonderful to just feel like, wow, I feel more like me than I thought I was going to.
Definitely.
Yeah. So Dani and Kristina, both of you have made reference to HRT, which we'll come back to in a second. But Dr. Burkland, I think one thing it would be really good to just level set on before we transition into that part of the conversation is, there's a few different surgeries that are associated with ovarian cancer risk management. There's removal of the uterus, there's removal of the ovaries, there's removal of just the fallopian tubes. So I guess, could you just sort of walk the audience through which of these surgeries induce surgical menopause and how that differs from the natural menopause that people go through?
Great. So I usually start by talking just about the three organs and what they do, and not kind of assume everybody's in the same space with that. And so I think of the uterus, it's a vessel. It creates a period for you, monthly if you choose to, by hormones that are made by the ovary that are acting on the uterus itself. But the uterus itself doesn't actually make any hormones. And you can remove the uterus just itself and you'll no longer have a period, but as long as your ovaries are still present, you will not be in menopause. So just removing the uterus for a BRCA patient would not be a risk-reducing surgery, since the main risk is with the ovaries. Then there's the fallopian tubes, which is the word salpingo or salpinges, when we say bilateral salpingo-oophorectomy. And those are really just a highway between the uterus and the ovary. They have like cute little fimbriated ends that kind of coat the ovary and catch the eggs when people are conceiving. But other than being a highway from one place to another, they're not actually creating any hormone either. You can remove the fallopian tubes as part of a contraceptive plan or sterilization plan. You will still have normal cycles because you have a uterus and you have ovaries. And then there's the ovaries, and these are the magnificent organs that make eggs that turn in somehow into humans. And despite 20 years of delivering babies, I still don't quite understand how that all happens. And it's a pretty amazing process. And it has many different types of cells. And there are three main hormones that we talk about when we think about the ovaries. And one is estrogen, one is progesterone, and the third one would be testosterone. If you remove the ovaries, even if you keep the uterus, you won't have a period because you have no hormones. So there's nothing telling the uterus to build a lining and shed a lining. So when we talk about surgeries for patients who have BRCA, we typically talk about risk-reducing bilateral salpingo-oophorectomy, so taking out both tubes and both ovaries. And this is what's been shown to show a reduction of 80% in ovarian cancer in patients. And so generally, you don't necessarily need to remove the uterus for a BRCA patient. There's some reasons for people to consider that. So when you're talking about a risk-reducing bilateral salpingectomy with oophorectomy with patients, that can be done laparoscopically with maybe a 1 to 2 week recovery. Adding the hysterectomy sort of extends that recovery and increases marginally complication rates than just taking out the fallopian tubes and the ovaries. And so you have to kind of go through the pros and cons of that. The standard sort of NCCN recommendation would be just to remove the tubes and ovaries, and that person will be in menopause. The deliberation about the uterus, and I'd be interested to hear Dani and Kristina's thoughts on this, but early on, there was thought that there might be more also increased risk of uterine cancer in patients who have BRCA. And subsequent studies, it seems like it's probably confounded by tamoxifen use in patients who had breast cancer before they had their risk-reducing procedures. And so that doesn't really seem to be panning out. But one advantage of removing the uterus is that you only need estrogen for hormone replacement. And when you look at the estrogen and progesterone versus estrogen alone and their risk of breast cancer in non-carriers, the estrogen alone arm doesn't increase the risk of breast cancer. It was in the estrogen plus progesterone arm. And so by removing the uterus, both of you guys really only have to take the estradiol. And so really the concern about whether there's an increased risk of breast cancer for you guys is going to be mitigated by the fact that you're not taking the progesterone.
Yeah. Dr. Burkland, and apologies because this was not in the script, but I thought about it while we were talking. So like, for example, for myself, I'm 38. I'm a BRCA2 carrier. And as you talked about, my lifetime risk of ovarian cancer is a little bit lower than a BRCA1 mutation carrier. So one of the things my doctor and I have talked about is just a removal of the fallopian tubes, and then having a natural menopause and then having the ovaries out. So I don't know if that's something you feel that you can sort of speak to, because there does seem to be a trend of like fallopian tube removal, natural menopause, and then ovary
Yeah.
removal.
Yeah, so the process of doing risk reducing BSOs really started in the late 90s. And so when you looked at patients who had theirs prophylactically removed, we found not only about a 1 to 4% occult malignancy, meaning that they went in for their preventive surgery, but they actually were found to have ovarian cancer at the time. But then we also were identifying what we think is a precursor to ovarian cancer. And those are called TICs, or tubal intraepithelial carcinoma. And those were arising in the ends of the fallopian tubes that sort of bathe the ovary. Like how I was saying, it has these cute little fingers. One of the most like beautiful things during a C-section, when I was a student, I always like put the little fallopian tube into a cup of saline, and you just see how magical they are. But those magical ends are the problem. And that's where those tubal intraepithelial carcinomas arise. And so the thought now is that perhaps there is a role for just offering removal of the fallopian tube at a younger age, where you're not going to need hormone replacement at that point, but still affording you some measure of protection. At the current stage, we don't know that this is going to have what magnitude risk reduction it would have for patients. And so it's really being done in clinical trials, and there's several that are going on. If you go to clinicaltrials.gov, I've had a few patients in my institution that I've sent them to the GYN oncologist for their surgeries and are kind of thinking about staging. And so if you're done childbearing, say at 30, but you don't want to, you don't necessarily need to that early have your ovaries removed, you could think about that as your contraceptive method, right? You could say, I'm going to have an opportunistic, because we can't technically call it risk reducing salpingectomy yet. I'm going to have an opportunistic salpingectomy and remove my fallopian tubes for my contraceptive management, and that also reduces maybe hormones that you would use alternatively, and then proceed with the oophorectomy at the recommended age.
Yeah. Thank you for that. And I'd love to just kind of now do a little bit of a dive into hormone replacement therapy, to actually just like, level set for the audience, just like what that is, what hormones actually get replaced, and kind of the levels at which those hormones get replaced with HRT.
Yeah, and so I wanted to circle back to part of the question, and something that Dani alluded to too, is that when patients are going through their risk reducing BSO or a BSO with a hysterectomy too, often those surgeries should be done by GYN oncologists. There are special surgical protocols as well as pathological protocols for that tissue to be managed. But the GYN oncologists aren't necessarily all going to be comfortable with like what's the best management of hormone therapy for patients. And so if they're not actively talking to you about hormone therapy, you should be talking to your gynecologist or somebody like myself, because starting your hormone replacement immediately is ideal, to not go through such an abrupt transition. Most people who go into menopause naturally have 7 years of waxing and waning and ups and downs, and a respite here or there where their ovaries are working pretty well, and then maybe a bad month here or there. When your ovaries are taken out, it is just full on down. And so it's really important. And I've definitely gotten those calls of like trying to squeeze somebody in, and it's like December 24th, and I'm like, how am I going to get this person in so I can actually meet her for therapy?
Yeah.
So definitely make sure that you're thinking about that. And if you're a GYN oncologist, and really we should save our GYN oncologists to do all the complicated surgery. I want no part of that complicated surgery. I love taking care of patients and love menopause management, both in my breast cancer or my BRCA patients, as well as my non-BRCA patients. So hormone therapy. And just to give you guys like a background, when I first started training, that was right after the WHI study came out, and like everybody and their mothers and sisters and aunts, everybody just dropped their hormones. And so I trained in the 4 years in which nobody learned or taught us hormone therapy. So
I know.
I really spent, the last 10 or 15 years really honing this and understanding it better, and feeling like not only have we done a disservice to women, but also like a disservice to our trainees. So what are the hormones that we need to replace. So the main hormone that causes most of our disruption is estrogen and the lack of estrogen. And so that's what's going to, replacing estrogen is going to ameliorate your menopausal symptoms. There are various dosing options available, and generally the recommendation is to start with the lowest dose. I do find now that we have these really, really low dose, ultra low dose estradiol patches. They often don't work for patients, so I usually start at the second or third level. And then, you know, adjust as needed. If patients have adhesive allergies, there is a gel formulation that you can use daily as well. So that's another thing to kind of know about. And then in terms of other benefits, besides your hot flashes, your night sweats, your sleep is going to improve, your mood's going to improve. And then long-term benefits of bone protection, cardiovascular health, and brain health. And when you look at non-hormonal options that are available to patients, you don't necessarily have the improvement in those long-term outcomes. And even some of the short-term outcomes or their short-term symptoms are not going to be as well ameliorated with non-hormonal options. The second hormone that we talk about is progesterone, and progesterone the lack of it doesn't really cause too much trouble for patients. There's some evidence that suggests that it might be helpful for sleep, but otherwise you could not have progesterone and you'll still feel great. But if you have a uterus and we give you estrogen without progesterone, you can develop uterine cancer over time. So that's the only reason we add progesterone to hormone therapy is when you have a uterus in place. I always think of progesterone, PRO, it's the protector of the uterus. And when you have unopposed estrogen, you're not protecting the uterus. Those cells overgrow, start dividing, and then you have a uterine cancer. So if you don't have a uterus, if you had that removed at the time, then you don't need it. But if you do, then you do need progesterone. And oral progesterone is generally the recommendation. Some patients don't tolerate that as well. You can use the levonorgestrel IUD, which is a type of progesterone, which has less systemic absorption. And so some people who feel moody or bloaty on the progesterone will sometimes do that instead. And the third hormone, that's not really for today, testosterone, because that could be a whole nother hour-long symposium. This is the one related to your sex drive. And actually testosterone levels in women start to decline at age 30. So it's not in your head. It's not that life is too busy. Your testosterone levels from age 30 are going down already. And so when I say it's not in your head, like lots of patients don't talk about it as much, but there is definitely less interest and less initiation of sexual activity once we get over that 30 years of age. I think I'll stop there and kind of have Dani and Kristina, I guess, answer your next questions.
Yeah, no, thank you. But that was a really helpful overview. So Dani and Kristina, both of you, have sort of alluded to using HRT. And I would just say, like, to the extent you feel comfortable, just like, if you could share maybe what drove your decision to do that, and just any advice either of you have for people who are preparing to undergo these surgeries, especially in terms of like adjusting to the effects of cervical menopause. So Dani, if you want to go first, and then Kristina, jump in.
Yeah, I like I said before, I always knew that I was going to do the surgical menopause. What I didn't know though, and maybe it was just being naive, or I just didn't ask my doctor the question of what happens after surgery. I actually don't recall having that conversation. I know I went and met with the doctors with my two sisters. I don't recall her answer, but I woke up from surgery with the patch on, with the estradiol patch. And so my doctor, who is very well versed with BRCA related cancers and does a lot of these types of surgeries, she knew to put me on this patch. She put me on the lowest dose, and it didn't work. And when I say it didn't work, maybe I had some hot flashes, and I was just very sensitive to that. So within probably a week, I upped the dose, and all was well. I mean, really, for 6 years, maybe 7 years, I didn't need to touch the patch. Same dose, no issues. 6 years later, 7 years later, I needed to up it again because I realized I was starting to go through some more of the menopause symptoms. But I really didn't have many complications or issues with, with the surgical menopause. I'm not sure about Kristina.
Yeah, I feel like my surgical menopause symptoms, well, first of all, my doctor, yes, the patch was on immediately. It wasn't even up for debate for me. I was 36 when I had my complete hysterectomy. And for my brain and my heart health, we knew that that was something that I absolutely needed. And I had already removed my breasts. I felt very comfortable. I read through all of everything that my doctor had available to me, and it just felt like the right choice. I will say that for me, if I am not a big drinker, I am not somebody who socially drinks a lot, but I will say that my symptoms of menopause, if I had a glass of wine, one glass, I would all of a sudden feel like this is what a hot flash is. I had my first one while I was out with family. It was actually last Thanksgiving. We were out, I had a glass of wine, and I thought I was having a nuclear meltdown. Like, I was like, what is going on? I am like really hot. And it dawned on me that, oh, this is a hot flash. I know it sounds silly when it should be so obvious, but that was like the first big thing. And I will say that for the first time in my life, I had always felt like, I will describe it as the way that you may feel, or I know I used to feel the day before my period, where I'd be like, am I losing my mind? Is everyone irritating me? Like that feeling of irritability was something that all of a sudden I was dealing with much more frequently. So that was my signal that I needed to increase it wasn't hot flashes, it was my mood. I felt really low, and that's not my baseline. It felt like the day before I get my period was consistent. And I wasn't getting a period anymore. So those were like my main symptoms that I was tackling, and it regulated out after a little while. It was definitely, for me, I wasn't changing my patch properly. So I have a twice weekly patch. And what that means is that I change my patch twice a week. And I thought that meant I could change it any day. I'm sorry, during that time of day, on that day, anytime during that day. I wasn't consistently changing the patch like every Thursday at 8 a.m. So I had my timing off, and that dip that I would feel in that, because it's a time release patch, that dip that I would feel would all of a sudden be like, wow, I'm really low energy on patch changing days. So I would highly recommend, if you are starting out HRT, to kind of keep a log on your phone. Take a look into what you're feeling like on certain days, and you can start to see if there's a pattern happening. You might not be using your patch appropriately.
That is a really helpful insight.
Yeah. And I also, if you don't mind, I just want to add, many years later, most recently, probably within the last year and a half, I was diagnosed with metabolic syndrome, and my doctor said that was a direct result of going into very early menopause, which, it was weight gain, it was, just independent risk factors for heart disease and stroke, and so it all is related, and so we were able to increase the dose and really level everything out. But that there's definitely, it's not just put the patch on and forget about it, set it and forget it. It's more, you need to keep an eye on it, really be in tune with your body, and and if anything seems off, you just need to get it checked out.
For sure.
Yeah. I'm mindful, we've been having a really great conversation, and I want to make sure we leave some time for questions. So my final question for the panel, which is for you, Dr. Burkland, is just like, what, given that BRCA1 and 2 mutation carriers are at risk, for breast cancer, ovarian cancer, pancreatic cancers, other cancers, what are the risks of HRT for mutation carriers? And in particular, are there any risks for a BRCA mutation carrier who has previously had a breast cancer diagnosis?
Yeah, so excellent questions. The specifically somebody who's had breast cancer, the recommendation would not to be using a systemic estrogen therapy, and that would be considered contraindicated. And so we'd have to talk about other management strategies and medication alternatives for them. For BRCA carriers with no history of breast cancer, hormone therapy is acceptable. I always counsel patients that we don't have years of data and long-term data in terms of, like, one of the questions that came up when we were getting ready for this is how long do you continue the hormone therapy? And it sounds like we give edgy answers because we don't really know the answers to that as well as I would say I'd like to know. And we're probably getting to that stage if you think about if the late 90s was when the studies were done to show that this was something that we should be doing. It's, patients like Dani and Kristina that are going to have another 15 years of probably using hormone therapy. And, hopefully we will have better, answers that confirm our feeling that this is not increasing the risk of breast cancer or reducing the benefit that you would get from your prophylactic mastectomy. I want to say, like, some reassuring information from the WHI study and being able to follow those patients out longer is in the estrogen only arm that didn't have any increased risk of breast cancer. Those patients are continued to be followed, and they're showing that some of the tools that we use to predict cardiovascular risk are actually decreased in those patients that started the hormone therapy in their 50s. So I think hopefully long term we will be able to show that it also is definitely cardioprotective when it's given to the right age patient. One of the flaws with that study is many of the patients were over the age of 60, and so were re-exposed to hormones they hadn't seen in 10 years, which is much different than giving somebody during the transition. And then in terms of things kind of down the pike potentially for those patients with breast cancer, recently there's a new FDA approved medication. It's gotten a lot of commercial advertisement called Veozah or fezolinetant. They have isolated the thermoregulator center in the brain, and more specifically the neurons responsible for controlling your temperature, and have developed a class of medications that affects just that. It improves the hot flashes by week 1 or 2 for patients, which is actually a little bit faster than estrogen, and really minimal side effects and minimal contraindications to taking that medication. Now, when they did the studies, they did not include anybody who had any sort of cancer, including breast cancer patients. So we don't necessarily have studies based on this for breast cancer patients. But I have at least 2 patients with breast cancer who really were struggling in their lives. They were sort of in male-dominated career fields and being like the only person in the room, like drowning in a pool of sweat while giving a presentation, and just feeling there was no culture of sympathy in the room for them, and have decided they're going to go ahead and take the medication because it doesn't really seem like there should be any increased risk of estrogen happening for them. There's also a fetal estrogen that is neutral effect on the breast. And I think that will probably be the next thing in development that will give our breast cancer patients options outside of some of the alternatives, which don't necessarily address all of the problems of menopause. They focus on the hot flashes and night sweats, but not necessarily the other aspects like the bone, the cardiovascular, the cognitive impairment that women experience with the lack of estrogen.
Got it. Well, I want to make sure we do have a few questions in the chat, so I want to try to get to a few of those. The first question, which I think is for you, Dr. Burkland, is you made a reference to the fact that we now think there might be this connection between pre-invasive lesions and ovarian cancer. Are those pre-invasive lesions one that can be detected on an ultrasound?
No, so these are, when we describe it as intraepithelial, that is basically one cell layer. A cell is something that's microscopic. Everything you're seeing on ultrasound is macroscopic. If I was looking inside your body, I could see that with my eyes, not using a microscope. So these intraepithelial lesions are within the tiny thin layer tissue of the fallopian tube, which the fallopian tube itself is about the size of half of a straw, and the wall dimension is also similar to that. It's incredibly thin. So it's not something we're going to see on ultrasound. Things that they've been looking at is those cells will exfoliate. And so could we go in with a hysteroscope, which is a camera that goes into the uterus, the same way a colonoscopy has a camera that goes into the colon, and then do washings in the fallopian tube to see if we can identify those exfoliated cells, similar to the idea of a pap smear, except for that's more external because that's the opening of your cervix. And then they're looking at other things like uptake of different metabolites using these kind of more interesting imaging techniques, but they're not ultrasound based.
Got it. The next question, which I will also direct to you, is what if you carry a BRCA1 or 2 mutation but have no family history of cancer? Do you still suggest the same precautions and surgeries?
That is an interesting question, because why would you have gotten tested? I don't know if I've had that clinically ever come up. I think I'd probably have to look at the, how much of the family history is known, how large are the progeny. So like, what if there's like no siblings? And so you go all the way back and you're still only talking at the great grandparent level, 6 people that you're looking at, as opposed to what sounds like Dani and Kristina have pretty large families. And so you have lots of different siblings in each of the generations, and it's a lot easier to see the pattern there. But I think, if they truly have that mutation, I would still recommend those indicated surgeries.
Got it. And then, hopefully, I think we can get through a couple more. Is there any good guidance for breast screening throughout the childbearing cycle? Trying to conceive plus pregnancy can be a couple of years. I've been told mammograms and MRI may not be safe during that period, and that imaging is less reliable during breastfeeding.
So, okay, there's a lot there. So I would say that, yeah, they'll be getting screening, and you should be thinking about your screening in terms of relationship to your fertility planning. So I do sometimes find patients who've been in the IVF cycle for so long that wasn't working. They've gone 3 years without breast cancer screening and are now seeing me for their prenatal visit. And I'm like, okay, please have nothing on your breast exam today, right? And I've taken care of a number of patients with breast cancer during pregnancy too. So definitely make sure you're getting those done. You can certainly do them while you're trying to conceive. Mammography can be done in pregnancy and postpartum and shield the abdomen and protect the fetus. And lactation does make it harder to interpret imaging, but it's not that it can't be done. And so I tell patients to bring a breast pump with them, and when they're getting ready to be called, to empty their breast as much as possible of the milk. And then of course the radiologist has to take that into consideration.
Yeah. Okay, 2 more. I'm gonna try, hopefully maybe we can run a couple minutes over. Dani and Kristina, to the extent that you both feel comfortable, could you share a little bit about the decision to also remove the uterus? And if you don't want to, I'm happy to we can move on to the next question.
Yeah,
Sure,
I mean,
go first.
for me,
Yeah.
it was really, I never really considered not removing the uterus. My aunt had primary peritoneal cancer, which is the lining of the abdomen, and you can't remove that. So I wanted to remove every organ that I didn't need that that was in my body. And so it was really never a question that I wouldn't. I remember when I met with the GYN oncologist at Sloan Kettering, at the beginning of our meeting, he said, no, I'm not in favor of this. And maybe it's the fact that I'm a lawyer, but by the end of our visit, I was able to convince him to agree to do it. And at that point, I decided to go somewhere else. But I really never considered otherwise.
I'll be honest, I went into it weighing every single option, and that was because when I at 36 thought my thing was I wanted to just have my fallopian tubes removed. That was what I initially set out to do. And then when I talked to my doctor, it seemed like, okay, wait a minute. If I really want to go with my goal of reducing my screening, I'm going to have to remove my ovaries. Then it became, well, if I'm going to remove my ovaries, why would I hold on to my uterus, was what I thought of, because I don't really need it anymore. There's no point for me to keep it. The only reason why I would have kept it was because I did not want to have the longer recovery. Like adding those few weeks on to my recovery period was the reason why I would have kept it. But when we kind of put that in place with our childcare and our support team, it was like, this makes the most sense for me. And also, to Dani's point, removing the largest amount of risk. I didn't want to go through all of this to still have any risk that was within my control.
Not to mention the increased hormones that would need to be.
Yeah, that was another thing too. I was like, well, I'd rather have one straight shot of dealing with just figuring out what estrogen levels I would need rather than the cocktail of hormones. Just seemed complicated.
Yeah. If everyone can, maybe I would love to just try to get through one more question. So apologies that we're going a couple minutes over. Dr. Burkland, could you talk about S-string as an option for BRCA carriers who have had breast cancer and have gone through surgical menopause? Is this considered safe?
And so the S-string, they're talking about vaginal estrogen. Yes, vaginal estrogen is not systemically absorbed to any appreciable level. And so patients with breast cancer can use vaginal estrogen to improve both sexual function. It's not just that, but it's also bladder function. There's a ton of estrogen receptors around the urethra and the bladder. And so you have a lot more overactive bladder symptoms in patients who are in that improve. Even recurrent urinary tract infections improve with topical local estrogen therapy. If you're taking systemic estrogen, you don't always need to supplement with vaginal estrogen, but I do sometimes, especially in these lower patches, find that some patients still develop genital urinary syndrome of menopause, which is a very fancy way of saying menopausal vaginal symptoms. And will also offer like additional vaginal estrogen to improve sexual health. And so the estrogen is just it's just a ring form of that, and definitely okay to use it. One small caveat is there's one study in aromatase inhibitors that saw the estradiol levels go up in the blood that we all sort of think was sort of an clinically irrelevant finding. But I always counsel patients on Arimidex. That might be the one to avoid it on. But honestly, Arimidex makes the vaginal tissue so much worse that I personally would still recommend it.
Got it. Well, I just want to say thank you so much. We are at time. If there are any questions we weren't able to get to, Carolyn Brown, who is our at the Basser Center, works with the YLC. Her contact information is shared in the chat. I just really want to say, first off, thank you to the Basser Center for organizing this. Thank you so much to Dr. Burkland and Dani and Kristina for their time, because everyone is super busy. This was like super great and informative. And again, if you have questions, please, visit basser.org or feel free to reach out to Carolyn. And have a wonderful evening.
You can reach out to me as well. I'm an open book. So if anyone has any questions, I will answer anything.
Yeah, same here. You can always reach out to me. The best way to get in touch with me is through Instagram. And I'm sure Carolyn, I told her she could certainly share my email. But real quick, if you're on, I want to leave a message for everybody here tonight, just so that we can all know that we've shared this experience together. We have all been touched by something that is really difficult to go through, and we've all received some sort of collective trauma. So to close tonight, I just want to say that the best thing that you can do is visualize yourself as healthy. If that means every night before you go to bed, you're just visualizing a white light over your body, knowing that you're doing the right thing for your body, that's one of the best things that somebody told me to do. And I know that a lot of us feel like we're being buried. But the one thing that I want to leave you all with is that after I completed both of my surgeries, I recognized that all along I was being planted, and it's your time to bloom. Everyone here is going to do fine no matter what you choose to do. You will be happy and healthy and live a wonderful life. So thank you all so much. Erika, thank you so much for moderating. Dani, was a pleasure, and Dr. Burkland, same.
Thank you.
Thank you everyone for joining.
Thanks.